I am Dr. Osama Shafii. We will discuss today the neurodiagnostics in ER. We will discuss the important tools for diagnosis of different neurological emergencies like stroke, like encephalitis, like meningitis. We will discuss at first radiology, CT and MRI. Then we will discuss the CSF examination. We will start with the CT scan of the brain. As regards the patient's preparation before doing the CT scan, there is no special preparations, but in some cases we need the patient to be in a fasting state for about 5 hours before doing the CT scan. In cases of the patient is in need of for anesthesia, like in children or uncooperative patients, or the patient will take contrast media. The second item is a scanogram. This is a picture of the scanogram. The scanogram starts from the base of skull like here and then advances every 1 centimeter in adult and 7 millimeter in children, and these cuts are shown in the CT scan. The third item is the contrast media. The contrast media is not a routine for ordinary CT scan. In the ER, patients are suspected with cerebrovascular disease, stroke, or trauma, so no need for contrast. This slide shows the different planes of brain imaging, either CT or MRI. This is the axial or the transverse. This is the sagittal, and this is the coronal. And this slide shows the film of normal CT scan. This is the scanogram, okay, starting from the baseline like here and then advances proximally. The first cut here in the base of the skull is this plane. So starting from here and then advances upward like this till reaching the high parietal lobe or the vault of the skull here. To read a normal CT scan of the brain, at first you need to identify the plane as we described before. So this plane is what? Is it axial or coronal or sagittal? Yes, it is axial cut or transverse cut. Okay, then we need to identify the normal parts of the brain in the CT. Okay, we will divide the CT brain into 3 parts. The first part before the lateral ventricle. The second part is at the level of the lateral ventricle, and the third part is after the third ventricle. We will start with these cuts before the appearance of the lateral ventricle. These cuts are called the posterior fossa part or the posterior fossa section, and the main landmark here is the fourth ventricle. Okay, the fourth ventricle size will change by changing the cut. From below upward will be narrow, then wide, then narrow again. So you need at first to search for the cut in which the fourth ventricle is wide. Okay, so in this cut, where the fourth ventricle is wide, there is the bones in front of it, and this is the prepontine cistern containing the basilar artery. When you go to the cut below, the cut with the wide fourth ventricle, you will find it has become very narrow like this. So in the cut below, there will be the medulla below the bones. And this CSF space is called the cisterna magna. If you go one cut above the cut with the wide fourth ventricle, it will be very narrow again. So this will be the midbrain, and this CSF space will be the quadrigeminal cistern. So again, these are the cuts before the appearance of the lateral ventricle. We will start by looking for what? Looking for the right fourth ventricle here. So this is the bones. When to go below, the fourth ventricle is narrow, and this is the medulla. When we go above, the fourth ventricle is narrow again, and this is the midbrain. This is the quadrigeminal cistern, and this is the cisterna magna. Then we will proceed to the cuts with the lateral ventricle. This is the lateral ventricle. When it appears, this is the second part in the CT scan. This is the frontal horn of the lateral ventricle, and this is the third ventricle, and this is the quadrigeminal cistern, and this is the occipital horn of the lateral ventricle. The third part is the cuts after the appearance of the lateral ventricle. These are the cuts, and you don't see CSF spaces like the other cuts at the lateral ventricle or before the appearance of the lateral ventricle. By now, we had identified the important CSF spaces within the brain, like the lateral ventricle, third and fourth ventricles. We will identify the loops. How to identify the loops? Frontal, temporal, parietal, or occipital loops. You will go to the level of the lateral ventricle and draw a line like this in front and behind the lateral ventricle. So in front of this line, it will be the frontal loop. Behind it will be the occipital loop. Okay? But between the lines, it is either the parietal loop or the temporal loop. How to differentiate between parietal and temporal loops? You search for the third ventricle. The third ventricle, if the third ventricle is there, so this is the temporal loop. If it is not, it is the parietal loop. Okay, again, we draw two lines at the lateral ventricles. In front of the line is the frontal loop. Behind the line is the occipital loop. In between, it is either parietal or temporal. To differentiate between them, we look at the third ventricle. At the third ventricle, it is the temporal loop. If there is no third ventricle, it is the parietal loop. The cuts after disappearing the lateral ventricle from above, there is no occipital loop. It is either frontal or parietal, the higher part of the brain. The cuts below the level of the lateral ventricle, we have here, this is the cerebellum. This is the cerebellum. This is the temporal loop. This is the frontal loop, temporal loop, and the occipital loops. So to describe the CT brain, we said we need to start with the CT plane. It is either axial, coronal, sagittal. Then identify the normal parts, identify the CSF spaces and loops of the brain. Then identify the pathology or the abnormal finding in the CT brain. To describe the abnormal finding, we have certain terminology for CT. For CT, we say dense. Okay, dense. It is either the lesion is either hypodense, hyperdense, or isodense. Hypodense, so the density of the lesion is less than the normal. This is the normal brain tissue, and this is a hypodense area. It is black than usual or more dark than the normal brain tissue. And this is a hyperdense lesion. Hyperdense, the lesion is brighter than the normal brain tissue. And this is the isodense lesion. It is nearly similar to the brain tissue. Hyperdense lesions that may present in the CT scan may be blood, like this, may be calcification. Calcification, so you look, the density is nearly similar to the bone. There is difference between blood and the bone. Okay, bone or calcium are more bright than blood. And there is normal and abnormal calcification. This is abnormal calcification in the basal ganglia, and this is normal calcification. Normal calcification may be present where the pineal gland here and in the choroid plexus. So this is normal sites for calcification, the choroid plexus and the pineal gland. And maybe this calcification may be abnormal, maybe another example for hyperdensity may be the blood. And examples for the hypodense lesions in the CT brain include the most common is the infarction, fluid like edema, infection, or tumor, hydrocephalic changes, the white CSF spaces as we see here, or presence of air within the brain tissue. Now we will talk about one of the most important findings in the CT brain in the ER, which is the infarction or ischemic stroke. At first, can you describe this CT scan? This is an axial cut, right? This is the lateral ventricle, okay? So, in front of it is the frontal lobe. This is the occipital lobe. And here is the third ventricle, so this is the temporal lobe. Can you identify any abnormality here? Look, this part, we see it is more dark than the normal brain tissue, so it is called hypodense lesion. It is a hypodense lesion of the right cerebral hemisphere. And this hypodense area is in the territory of the middle cerebral artery, which is occluded by infarction, included by thrombus or embolus, okay, causing infarction of this part of the brain. Okay, this is another example. This is a transverse cut or axial cut of the CT brain showing hypodense area, the right temporal loop, right, in the territory of the upper division of the middle cerebral artery. Look at this CT brain showing what? Hypodense area, okay, the temporal loop, okay, and temporo-occipital part. So the stroke is affecting the inferior division of the middle cerebral artery. Can you identify the abnormality in this CT? You see, here is the hypodense area, the basal ganglia. And this is another hypodense area. This is a hypodense area in the thalamus. So it's basal ganglia and thalamic infarction. Where is this lesion? This hypodense lesion is in the frontal lobe. It is in the territory of the anterior cerebral artery. Where is this lesion? It is a hypodense area. Where? Okay, this is at the level of the lateral ventricle, right? Line. This is the frontal lobe. Second line, this is the occipital lobe. And this is the temporal lobe, because this is the third ventricle. So it is infarction of the occipital lobe. The second important item in the CT brain pathology or abnormal finding is the intracranial bleeding. Bleeding is either extradural, subdural, subarachnoid, intraventricular, or intraparenchymal. This is the dura. Okay, so if the bleeding is outside the dura, it is extradural or epidural. If it is under the dura, between the dura and the brain, it is called subdural. If the hemorrhage is inside the brain tissue itself, it is intraparenchymal. If it is within the CSF spaces, it is intraventricular. If it is below the subarachnoid spaces or inside the subarachnoid spaces, it is the subarachnoid hemorrhage. So at first we identified this lesion is a hemorrhage because it is brighter than brain tissue or hyperdense lesion. We saw a hyperdense lesion here. We saw a hyperdense shadows here inside the subarachnoid spaces. This is the normal CT. So at first we need to localize this hemorrhage. Where is it, extraaxial or it is intraaxial? Intraaxial means it is inside the brain tissue. Extraaxial, it means it is outside the brain tissue, either epidural, subdural, or subarachnoid hemorrhage. The first one of the extraaxial bleeding is the epidural hematoma. Epidural hematoma is a hyperdense lesion like this. It is between the dura and the skull bone. It has a convex inner margin and it is almost always acute and caused by trauma. The second one is the subdural hematoma. Subdural hematoma is between the dura and the brain tissue and it has a concave inner margin like this. It is either acute, subacute, or chronic. In the acute, it will be hyperdense like this, okay, like the normal hemorrhage. The subacute stage, it will be isodense like this. You see, this is not a normal brain tissue. This is a lesion compassing the normal brain tissue. And in the chronic stage, it will look like CSF. It will be darker, so it will be hypodense. So the density changes with age. Of the subdural hematoma, at first it will be hyper, then will be iso, then will be hypodense. If you look at this CT, you will see a hyperdense lesion in the thalamic area and the intraventricular space. So this is a thalamic hemorrhage with intraventricular extension. Can you define any abnormality in this CT scan? Look at the CSF spaces, Sylvian fissure, the interhemispheric fissure. Is it normal? No, normally these are CSF spaces, so they are black or hypodense, right? It is whitish. This means it is blood here. Okay? So it is blood here in the interhemispheric fissure, in the sylvium fissures, in the ambient cistern, the supracellular cistern. This is a subarachnoid hemorrhage. Hemorrhage in the subarachnoid spaces. So in the ER, do we need MRI or the CT is enough? Okay. By now, we knew that the CT is very important in distinguishing ischemia from hemorrhage. But if the patient came to the ER with right side hemiparesis, for example, and we had CT brain, what do you expect to find in the CT brain? Okay, if the patient has a hemorrhagic stroke, we will see blood from the first time. From the first CT in the presentation, you will find the hyperdense lesion of the blood. But if the patient had ischemic stroke, CT may be normal in the few first hours of the incident or of the stroke. So the function of CT in this setting is to exclude hemorrhage and to give the possibility to diagnose the patient as ischemic stroke and start treatment like giving him thrombolytic therapy or other interventional procedures. So this may raise the need for MRI for further determination of ischemic changes inside the brain in the first few hours. At first, we need to identify the MRI scan or MRI film. MRI as CT has planes, maybe axial, maybe sagittal, maybe coronal. Okay, this is the axial or transverse plane. How to identify is this CT or MRI? By looking for the bone. In the CT, you see the bone like whitish area surrounding the brain. It is very bright, very obvious. Okay, MRI can see bone. So bone here is blackish. We have different sequences of the MRI. The T1, the T2, flare, and diffusion. T1 looks like CT, the CSF is black, and the T2 CSF is white. Okay, T1 like the CT, CSF is black, while T2 CSF is white. Like CT, we say in terminology we have hypodense, hyperdense, and isodense. Okay, in MRI it is intense, hypo-intense, hyper-intense, or iso-intense. So this lesion is hypo-intense. This is the hyper-intense. Do you see this faint lesion? It is nearly iso-intense. How to identify the infarction in the MRI? Infarction in the MRI, we look at the T1, T2, flare, and diffusion. This is the is this a CT or MRI? This is a CT because this is the bone and this is the MRI. Do you see the difference? Okay, this is a CT showing a hypodense lesion here. Okay, and this is the MRI of the same patient. This is the T1 because CSF is black, and this is the T2 because CSF is white. Okay, so infarction appears like there's a hypo-intense in T1 and the hyper-intense in T2. And we have something called restricted diffusion in the diffusion film. It means there is cessation of movement of water particles or blood in this area. This is the diffusion scan, and this is the flare scan of the same patient. This patient came with side weakness, left side weakness, the first 1 or 2 hours of ischemia, and as you see, flare is completely normal, and the diffusion here can show early ischemic changes. So you can easily diagnose ischemic stroke very easily and very early from the onset of the condition. So CT or MRI in the ER, what do you think? MRI is very helpful in diagnosis of early infarctions. Okay, but is it a routine? No. CT is the gold standard in the ER. Why? Because it doesn't consume time. MR consume much time, much more time. MR is more expensive and not available at all centers, and they need experts to read it. CT is more easily, more available. Anyone can read the CT. And you simply can exclude hemorrhage by using the CT, and so you will diagnose the ischemic stroke. And if you suspect the diagnosis of the patient, you will proceed for the MRI. So CT is still the gold standard in the ER for stroke. The part of our lecture today is the CSF analysis. When to order CSF examination? CSF examination is not a routine examination because it is an invasive maneuver and it has its complication. So you are asking for CSF examination only if you suspect certain conditions in the ER, like if the patient presented to you with high-grade fever, meningeal irritation signs, seizures, and focal neurological signs and symptoms. So you are suspecting CNS infection like meningitis or encephalitis. Or if you are suspecting malignant infiltration of the CNS like in leukemia. In patients with subarachnoid hemorrhage who are suspected with thunderclap headache, photophobia, neck stiffness with no signs of infection, okay, to confirm the diagnosis of subarachnoid hemorrhage. Also, it can help in the diagnosis of some conditions like demyelinating diseases as multiple sclerosis. Obtaining the CSF sample must be done in a complete aseptic condition to avoid the iatrogenic introduction of infection. Patient lie in a left lateral position with a flexed knee and neck, and the needle is introduced between lumbar 3 and lumbar 4 or lower. Why at this level? To avoid the injury of the spinal cord, which terminates at the level of in the adult L1 or L2. So you are going below the end of the spinal cord. So by now we have introduced the CSF needle and aspirated the sample. What will you do? We have a routine CSF analysis. The collected CSF sample is divided into 3 tubes. The first tube for chemical investigation, and it is kept in freezer. The second tube is for microbiological investigation, and the third tube is for microscopic investigations. Okay, first we need to know the normal values of the CSF analysis. It is divided into physical, microscopical, chemical, and microbiological. Okay, The physical, at first you look at the tube for the color and the appearance. Normally it is clear and colorless. pH is 7.4. The daily secretion is about 450 to 500 milli, and the specific gravity is 1.006 to 1.007. The microscopic appearance, normally no cells in the CSF or very few cells, very few lymphocytes from 1 to 5 high power field. Okay, no RBCs, no other white blood cells. This is the normal microscopic examination for CSF analysis. The normal chemical examination, including the protein, glucose, chlorides, are the most important three values for chemical examination: protein, glucose, and chloride. And normally there is no pathogenic microorganism in the CSF. So it is clear and colorless, with no cells, with normal protein, glucose, and chloride. So the normal CSF examination, as regards the physical examination, it is clear and colorless. Okay? Okay. Abnormally, you may find the CSF is turbid. Turbid means it contains some content that normally not present in the CSF, like bacteria, like white blood cells, like pus cells, and these cells are suggesting infection, like meningitis. If the color is changed, so you say it may be red or brown. Red or brown means it may be blood. Blood, it is suggestive of hemorrhage, like the subarachnoid hemorrhage, or you have injured some vessel during the procedure of insertion of the needle. So it may be traumatic tap or maybe subarachnoid tap. Okay, how to differentiate? We'll talk about it in the next slide. If the color is yellow, it may be jaundice due to the content of bilirubin, or xanthochromia due to prolonged presence of blood inside the CSF and the hemoglobin is broken down into pigments, which is the xanthochromia. Okay, and the prolonged duration of blood inside the CSF, it will be distracted into pigment. As we said, the bloody CSF may be subarachnoid or iatrogenic tap. To differentiate them, we have a test called the dilution test or three-tube dilution test. When I am aspirating the CSF, okay, we aspirate it into multiple tubes. Some in the first tube, then use the second, then use the third. Okay, if the cause is iatrogenic, you injured a vessel, right? You caused injury of a vessel. So when you are tapping, the first tube will be bloody. The second, the red color will fade somewhat. The third will be more clear, and after that it may return to normal. So this is the iatrogenic or traumatic tap. But what happens in the subarachnoid or presence of blood inside the CSF? All tubes will be like the first tube because the blood is present there. Okay, and the iatrogenic, you have injured a small vessel, it will cause some hemorrhage and will fade out, right? Okay, so if the color is fading like this, it is traumatic. If the color is persistent as the first, it will be hemorrhage or subarachnoid, for example. As regards the microscopic examination, we mentioned that white blood cells normally about 1 to 5 lymphocytes per high power field. Okay, if we are having increased number of white blood cells, mainly neutrophils, so it is bacterial, and if it is increased and mainly lymphocytes, it will be aseptic or viral. As regards the RBCs, normally CSF is blood free. Okay, if we have RBCs in the CSF, maybe subarachnoid or traumatic. And how to differentiate? By the dilution test. As regards the chemical examination, we will talk about the glucose, lactate, and chloride. Glucose level is decreased in the following conditions, like septic or biogenic infections. Why? Because there is a battle is going on there between the bacteria and the immune cells, the leukocytes, and they are consuming glucose. And this glucose consumption will lead to byproducts including the lactate. So the glucose level will decrease and the lactate level will increase in the case of infection. Brain tumor also consume glucose due to increased demand and the metabolism of the tumor cells. Also will decrease in the TB meningitis and sarcoidosis. As regards the CSF protein content is increased by any process that adds another constituents or components to the CSF, like the immune cells, like the bacteria, okay, or changing the permeability of the blood-brain barrier so cells can freely move into the CSF. For example, in the traumatic tab, you are causing hemorrhage, and this mild hemorrhage contains protein, okay, but it causes mild increase in the CSF protein. Increasing blood-brain barrier permeability causes cells to enter the CSF, like in CNS, bacterial and fungal infection or cerebral hemorrhage. Increased production by CNS tissue, like in demyelination or MS, it contains immunoglobulins like IgG. Obstruction of the CSF flow, like in the tumor or abscess. Regarding the CSF immunoglobulins, CSF is almost free from immunoglobulins, and it appears only if there is a disturbance in the blood-brain barrier or intrathecal synthesis of immunoglobulins. So we have a formula called IgG index. By comparing CSF IgG index by the serum IgG and CSF serum divided by the albumin index. Normally it is less than 0.7. If it is increased, this means this increased CSF IgG, which arise from plasma cells within CSF or from the blood through the blood-brain barrier disruption. How to differentiate between both of them? Increase the CSF IgG without increase in the albumin, it means there is local increase in the production of IgG within the CSF or intrathecal synthesis of CSF which occur in multiple sclerosis and subacute sclerosing band encephalitis. Another method to demonstrate the IgG within the CSF, like using the CSF electrophoresis, looking for oligoclonal bands. Oligoclonal bands, when it is present inside the CSF, it means there is intrathecal synthesis of immunoglobulin, which is distinctive from the blood immunoglobulin. As regards the CSF lactate, it may be increased in cases of bacterial meningitis due to increased glycolysis, okay, and lactate will be the byproduct from this process. Okay, this is a rapid revision for the interpretation of the important results of the CSF analysis by comparing the normal, bacterial, viral, and fungal meningitis. Appearance: normally it is clear. The bacteria disturbed due to presence of white blood cells and bacteria. Viral and fungal meningitis CSF is clear. The opening pressure is elevated in the bacterial meningitis due to high content of the cells, and they may be mild elevated in the fungal meningitis. White blood cells. There is marked increase in the bacterial meningitis. It is thousands of cells, mainly neutrophils. In the viral meningitis, it is hundreds, with lymphocytic predominant, and the fungal meningitis, it is between them. Protein content. There is marked increase in the bacterial and fungal meningitis and mild increase in the viral meningitis. Glucose. There is marked decrease in the glucose content in the bacterial meningitis, with normal or mild decrease in fungal meningitis. Finally, this is a quiz to remember the most important items in our lecture. You should identify this picture, if is it CT or MRI, and define the abnormality in it. This is a CT brain. Why? Because you can see the bone clearly here, right? The lesion is here. It is hyperdense lesion, so it is hematoma, intracerebral hemorrhage. Can you identify this picture? This is a CT brain showing what? Hypodense lesion in the right hemisphere. It is ischemic infarction causing midline shift. You see the compression on the ventricle and the shift of the midline to the opposite side. What about this image? It is CT brain showing a hypodense lesion in the left hemisphere. This is ischemic infarction, and this is another ischemic infarction. Can you see the difference in the color? It is more hypodense here. This means this is an old infarction, and this is a recent or more recent or subacute infarction. What about this image? It is a CT brain. Look here. It is hyperdense lesion. Is it epidural or subdural? It is epidural hematoma. How to differentiate between viral and bacterial meningitis using CSF? White blood cells, the viral meningitis, moderate increase, hundreds of cells, the bacterial, marked increase, thousands of cells, differential count, lymphocytic in the viral meningitis, neutrophils in the bacterial meningitis, glucose content, normal in the viral, marked decrease in the bacterial, protein, mild increase in the viral meningitis, and marked increase in the bacterial meningitis. Thank you for your listening.